Welcome, everyone, to the first webinar in our 2020 series. I'm Stan Mahabir of Discovery Campus, and I'm moderating today on behalf of Parkinson Canada. Today, we're here to talk about practical communication approaches on how to deal with the relationship issues stemming from mood and cognitive changes that occur as a result of living with Parkinson's disease. Today's presentation is titled Mood and Cognition, Non-Motor Symptoms of Parkinson's Disease and How It Impacts Relationships, with expert speaker Dr. Adriana Shnall. Dr. Shnall is the Program Director of Baycrest at Home, in charge of clinical programs, and the leader of the Koschitzky Centre Seniors Counselling and Referral Senior Support Program. Before we begin, I would also like to take this opportunity to thank Baycrest and Baycrest at Home. Questions will be answered at the end of the presentation by our speaker, and we will make every effort to answer all questions. Please join me in welcoming Dr. Shnall.
Thank you, Stan, for that introduction, and welcome everybody to this presentation. I'm hoping that you'll find it useful. And when I say things, if you have any questions, if you wouldn't mind writing them down so that you don't forget them, and we'll attempt to do that at the end. I want to start this presentation by talking about what we want to accomplish today. And I want to give an overview on mood and cognition, especially as it applies to Parkinson's disease. And we're going to talk about depression, anxiety, other emotional changes, cognitive impairment and dementia and psychosis, and then strategies on how to work around these issues. I want you to know that this was adapted from the National Parkinson's Foundation Handbook on Mood and Memory, and also from the Parkinson's Canada Handbook. And you could find those two online if you wanted more information. So it's really interesting because Parkinson's disease in the olden days, whatever that means, used to be considered a neurological disease. And so people went to only see neurologists, and they never thought of it as having a psychiatric or psychological component to it. Now it is classified as a neuropsychiatric disorder, and by neuropsychiatric we combine the neurological component, and those are the well-recognized motor symptoms, with some of the psychological symptoms. And what's important to remember is that these mental health changes are just as important as motor symptoms, especially for families. The most common mood changes in Parkinson's includes depression and/or anxiety, and actually up to 50% of people with Parkinson's experience some sort of a mood disturbance at some point during their illness. Mood disturbances really lead to worsening of function and quality of life. And despite their high occurrence and negative effects, interestingly or sadly, mood changes in people with Parkinson's disease are less well studied and understood than motor symptoms. Depression, anxiety, and other mood changes often are more disturbing to the person and care partner than motor symptoms, actually. So I'll focus briefly on depression, and actually up to 50% of people with Parkinson's experience depression at some point. And depression is not just something that occurs as a result of realizing that one's life is not the same. It's not just a psychological factor. There are actually other biological components that play a role. And what's important to remember is just because people have a reason to be depressed, it does not mean that they shouldn't be treated for it. Because a lot of the symptoms are caused by chemical imbalances in the brain. And there's good medication to help these symptoms of depression, just as for physical symptoms. So it's very undertreated with people with Parkinson's, and I'm hoping that if you get nothing else out of this presentation, is that if the person you care for is experiencing depression, that you raise it to the family doctor or whoever's following, and bring it to their attention, and actually ask for treatment. Some of this depression doesn't necessarily look like just lying in bed and doing nothing all day. Sometimes people experience feelings of guilt, thoughts of death or suicide, decreased interest on things that they used to find pleasurable. So if getting together with the grandchildren is not something that's causing excitement, but it's a source of distress, and before it was something that it was a happy occasion, those are things that you need to pay attention to. Also, having poor concentration and attention, having sleep problems, being slowed down or restless, and feeling worthless or blaming oneself for everything that's happening. And again, depression is really undertreated in people with Parkinson's. Anxiety, on the other hand, is less understood, and yet it may be as common as depression is in people with Parkinson's. Up to 40% of people experience some form of anxiety, and there's 4 types that are the most common, and I'll explain each one in turn. One is generalized anxiety, anxiety attacks, having obsessive compulsive disorders, and social avoidance. And actually what happens is that anxiety and depressive disorders often happen together. So, what's generalized anxiety? That's feeling like you're constantly nervous, that you worry about most of the time, feeling out of control. And with these, physical symptoms are also common. So, bowel problems, headaches, acid indigestion, back problems. Anxiety attacks look differently because they have more of a sudden onset to them, and there's a sense of severe physical and emotional distress with them. And so people would feel like they can't breathe, like they're having a heart attack. It really looks like a medical emergency is happening. And episodes generally last less than an hour. And that's generally at times when people have off moments, times, but they can actually last for longer periods of time. Obsessive compulsive disorder are really thoughts and behaviors that are repeated and that they're not really connected with real life problems. Generally, they don't make sense and they're actually troubling to the person, but they have no control of it. So your typical one is hand washing behavior. And social avoidance involves avoiding situations with other people. And a lot of the times it's secondary to fear of embarrassment about having Parkinson's disease. Other emotional changes that occur with Parkinson's are loss of impulse control. And this we call disinhibition. And I'll explain each one in turn: increased emotions or decreased emotions. And again, these emotional changes affect more than 50% of people over the course of their illness. So what's disinhibition? The most common behaviors are gambling and sexual preoccupation or acting out. All compulsive behaviors, including gambling, should really be reported to the physician because some of these behaviors may be related to medication and maybe get better if these medications are withdrawn. So don't keep this information to yourself. Don't assume that it's something not relevant to the healthcare team. Please share with them. Don't wait for the next appointment, but please call if you notice any changes. In terms of increased emotions, we see that some people just become more emotional, they're tearful, but this doesn't necessarily mean that there's depression happening. People don't necessarily feel sad during these episodes. These people say that these episodes come out of nowhere and they pass quickly. You don't necessarily need treatment for these, but sometimes if they're problematic, antidepressants and some mood stabilizers have been used with good outcomes. The other concern, and interestingly, this is a really difficult thing for care partners to live with, is where emotions are decreased. So people just show less emotions, there's less social interaction and less speech. So people just become what sounds like more apathetic. And apathy actually is a diagnosis, and it's a decrease in motivation or interest that goes along with decreased emotions, social interactions, and speech. And apathy can be connected to the thinking and mood changes that can occur in Parkinson's disease. And people may be unaware that they have changed in any way. People with apathy often need to be pushed to remain physically, mentally, and socially active. It's almost as if a part of the brain that keeps us going turns off. So, for example, even though when my alarm goes off at 5 in the morning, I don't feel like waking up. I still do because I have to, and I do it. Sometimes with people with Parkinson's disease, that part of the brain is not working so well. So that you as the care partner need to take on that role. A way to address this is by having structured schedules that keep people active. Another issue that I want to make sure we talk about is cognitive impairment. And I'll explain the difference between cognitive impairment and dementia because they're not the same. Over 50% of people experience some form of cognitive impairment, again, throughout the illnesses. And we can divide it into 3 stages. The first one, in the earlier stages, is when people are easily distracted. They lose train of thought when they're performing a task. And this could be really no different than many of us as we age, where we go into a room, and we forget why we went to the room. Or we put the milk in the cupboard instead of the fridge. The middle stages is when people really start noticing more difficulties, and these are difficulties with decision making, problem solving, memory, and word finding difficulties. So even small decisions may become hard for people with Parkinson's. For example, going to a restaurant, have a large menu in front of you and not knowing what to order. One way to deal with that is actually offering people a couple of things, like, would you rather have chicken or meat? In the later stages is when more serious cognitive disturbances arise, and there could be confusion, visual hallucinations, delusions, and agitation. And I will explain each one of them separately. And in general, mental and motor decline tend to occur in parallel as the disease progresses. So we don't generally see the confusion, hallucinations, delusions, agitations in the earlier stages of the illness. Cognitive impairment is affected by changes in the structure of the brain as well as chemical imbalances. But above and beyond this, people that have anxiety, depression, poor sleep can also worsen these cognitive deficits or appear as more problematic. And so there's not much we can do around the brain changes and the chemical imbalances. But there is something we can do about anxiety, depression, and poor sleep. And so these then would be the areas that need to be targeted in order to improve the cognitive impairment. Currently, there's actually no medication for cognitive impairment. However, dementia, there may be some medication, and that's up to the physician to discuss, that may stabilize things. The difference between dementia and cognitive impairment is that dementia, it's a continuum. So there's no magic score number or test that tells you that whether you've are no longer cognitively impaired and moving to dementia. Dementia is at a point that the problems in memory and thinking are interfering with daily activities and quality of life. So if somebody's managing okay but forgets certain words, but they can still do their banking, they're still perhaps able to drive, we wouldn't say that the person has dementia. We would say that they have cognitive impairment. And these dementia is more difficult, of course, for families to deal with because actually functioning is impaired. So a big point of a turning point is when people can't do banking, when people can't work. People can work with cognitive impairment depending on the type of jobs they have. But once somebody has dementia, it becomes problematic because they may not perform and then people may get fired. So this is something that it would be important to discuss with if the person you're caring for is still employed with whoever they're working with. And also it's important for you to be aware in terms of safety issues. The good news is that cognitive impairment occurs in the majority of people with Parkinson's, but dementia doesn't necessarily. And so that's good news in that although cognitive impairment is difficult to deal with, at least it's not as severe as it could become. And I'd be happy to talk about this a little bit later. The one area that I want to emphasize is psychosis, because generally this is one of the most difficult things for families of people living with Parkinson's to address. Is both psychosis and apathy are actually the most disturbing for families and the ones that cause most distress. Psychosis is a loss of contact with reality, and generally this leads to behavioral and emotional changes. And actually, psychosis affects up to 40% of people at some point in their illness. Typically, it's experienced as a side effect of medications. And that's the good news, that could be modified. But a number of factors and causes can also be involved, like dementia and delirium, and I will discuss those a little bit later on. Psychosis is one of the most challenging complications for families, for people living with Parkinson's, and actually for clinicians to manage. And if not treated, psychosis can become actually more problematic than the physical motor symptoms. Psychosis is actually identified as the leading cause of placement for people with Parkinson's disease. And as I said before, causes of psychosis could be medication side effect, could be due to dementia, and or due to delirium. In terms of medication side effects, in the majority of cases, Sinemet and some of the dopamine agonists are designed to increase levels of dopamine in the brain and therefore improve motor symptoms. However, high dopamine levels is what causes psychosis. So I cannot emphasize enough the importance of, if you notice any of these symptoms, to discuss it with your partner's physician. The other causes of psychosis include dementia. And again, it can result from changes that occur in the brain, regardless of things such as medications. And it's most commonly seen in cases of Parkinson's disease with dementia. Delirium, on the other hand, is reversible. And it's a change in cognition that happens from a general medical condition or metabolic abnormality. So for example, if somebody has a urinary tract infection, has the flu. People could look like they're confused. There's a very important change that you could not notice. Basically, it develops over a short period of time, hours to days. And once, say, the urinary tract infection is resolved, then the delirium is resolved as well. Whereas the dementia tends to be ongoing. It's neurodegenerative in nature, meaning that it's progressive, and treatment won't necessarily help. And again, I don't want you to think that if there's psychosis is just one cause, either medication, either dementia or delirium. What's difficult about it is that sometimes they coexist. In terms of what are the most common symptoms of psychosis in people with Parkinson's disease, these are hallucinations and delusions. Hallucinations can be visual. They could be auditory, so you hear something. It could be tactile, meaning you feel something. Smells are common as well, and even taste. And these are not based on reality, of course, but to the person with Parkinson's, they would appear to be very real. So there's no point in arguing that, it doesn't smell like skunk here because there is no skunk. I don't smell it. And I'll talk a little bit about how to deal with these with hallucinations. But most commonly in Parkinson's disease, visual hallucinations are the ones that occur the most, followed by auditory hallucinations, which are reported by only really a small percentage of people, and the other forms are really rare. So visual hallucinations, what do they look like? Actually, a common one would be something like your partner saying to you, look at all those trees there out the window. And you look out the window and there's only buildings. So you know they're not there. And that would be a typical hallucination. If they're not upsetting to the person, there's no point in dealing or getting very upset, because some of the hallucinations are quite comforting to people. So some people hallucinate, for example, that they see their mom who's been long gone, actually. And if this is something of comfort, why would you take that away? Delusions are very different in that they're really more thoughts or ideas that really most of the time are illogical, they're irrational, and they're dysfunctional. The person with Parkinson's truly believes that these thoughts, even though are not based in reality, they are true. And the good news is that delusions are less common compared to visual hallucinations, and they affect approximately 8% of patients. However, they can cause a lot of trouble. And they can cause a lot of trouble, and usually they're more difficult to treat than visual hallucinations. And here are some examples of delusions. Jealousy, for example. Your partner saying to you, I know you're dating the neighbor, I've seen you together, not trusting you, being possessive of you, being jealous of the fact, even if you were to go, say, out with your daughter or your son, that the person with Parkinson's just feels this intense feeling of jealousy. And they accuse you of things, again, not based on reality. The other type of delusion is a persecutory delusion. So feeling that their lives are in danger, that they're being attacked, harassed, cheated, conspired against. And this is, for example, a very common one is the police has cameras and they really want to get to me because they think that I'm a bad person, but I've done nothing wrong. And what's really upsetting about it for the person is that they truly are scared. And the last one is somatic. And so this is the belief that your body functions in an abnormal way, or people have an unusual obsession with their body or health. A very common one is having ants crawling under your skin. And no matter how much explaining you do that this is not happening, the person truly believes that this is what's going on with them. What's really important for care partners to understand is that these beliefs and ideas are really real to the person. You can't sit down with them and have a rational conversation about this. And those delusions of persecution, paranoid delusions, typically are more difficult for treatment. And they're difficult to deal with, not just for the person that has Parkinson's disease, but for the family and the clinicians as well. So I'm going to go through some practical tips for dealing with some of these psychotic symptoms. So the first thing that's important for you to do is talk to your loved one about what they're experiencing. And you can openly discuss their thoughts, their feelings, their symptoms in a non-threatening way. And this is to try to ease their anxiety and for you to understand what's going on with them. And for this, you need to kind of regain control, try to stay calm and be patient. Again, if you become angry, aggravated, demanding, the person you care for, your partner, could have an increase in aggression and agitation. Of course, easier said than done. But if you don't stay calm, if you're not patient with these delusions or hallucinations, things are just going to escalate. If the person you care for becomes agitated or aggressive, what to do? First of all, give space. Don't go closer to them. Try to be calm and talk evenly. Don't raise your voice. Be reassuring to the person. So say something like, everything's fine, you are safe. Try to keep your hands in view so that the person doesn't feel threatened, and your movements to a minimum. Try to ask how they're feeling and why they're feeling so upset, and listen to what they have to tell you. The other way that you can respond is by making adjustments to the environment. So for example, for visual hallucinations, lighting at night can help reduce shadows and risk of having visual illusions. Also, try to keep dangerous objects in secure locations. Make sure furniture is arranged so that the person cannot trip or fall. So especially at night, make sure that the path is open to the bathroom. If the person is experiencing agitation and or aggression, make sure that the environment is quiet and calm without disturbing noises or distractions. So turn off the TV, turn off the music, whatever kind of noises you can control, try to do that. When somebody's having a hallucination again or a delusion, do not challenge them by saying they're not real. Because as I said before, you're just going to agitate people more. However, this does not mean that you need to go along with the story and validating the really illogical behavior or ideas that they're having. So a phrase like, I understand that the trees appear real to you, but I can't see them. I wonder if they might be a hallucination, and leave it at that. The other thing that's important to do is to educate others who are frequently around your partner, around what psychosis looks like, and the mental health issues that arise in Parkinson's disease, because I can guarantee you that most people are not aware that these are other issues that affect people with Parkinson's disease. The more education you do for yourself and to others, the easier things will become so that others can understand what your partner, your loved one is going through. Also, allow people to help you. Don't be afraid to ask for assistance from family or friends, or ask for support from community health agencies. You don't have to do it alone. When somebody is experiencing a hallucination or a delusion, safety is really a priority. And this also means ensuring your own safety as well as the person that you're caring for. And people with psychosis can be confused, agitated, aggressive, suspicious, argumentative. And if things become out of control or you feel unsafe, leave the room and see if you can get help if anybody's around from somebody else. But you can call 911 for these things. And this is really what our services are here for. Again, you don't need to feel that you can manage this if you can't, because people, unfortunately, can become quite aggressive. And your only recourse may be to call 911. The other thing is try to explore available resources and options. And in rare cases, psychosis is really something that progresses despite treatment. And this can make care in the home really difficult. And at this point, it is appropriate to consider placement in a long-term care facility. And this could be either short-term or long-term. And social workers can be an excellent resource when considering alternative care options. So just to summarize before we move on to communication, a little bit around psychosis. It's really one of the most misunderstood and challenging complications associated with Parkinson's. Symptoms can involve change in behavior, thinking, and even personality sometimes. And if it's not properly identified and treated, it can quickly become the most distressing component of the illness. And again, these symptoms require the same type of attention as tremors, stiffness, and impaired gait. Management and treatment of psychosis can be complicated, but generally it is successful. So again, as you notice these symptoms, don't delay consulting your physician. So for the last bit of the presentation, I'm going to move into discussing some communication strategies. And I want to focus in two areas. One is actually communicating and the communication challenges with the person with Parkinson's disease. But I also want to address communication between carers, care partners, and others. And by this, I mean making your own needs known. I just want you to remember that it's not all about the person with Parkinson's disease. You matter, and you need to make people know that you matter. I wish that in our society, we realize that caregivers have a right to their own health and to be asked how they're doing, but I'm afraid that this is not necessarily true. So if you're not going to be asked, it's important that you can communicate what your needs are. So first, communication strategies for people with Parkinson's. And the difficulties with communication can occur for various reasons. One is actually the softened voice volume. It's just hard to hear. Also, having a masked face is hard to read expressions. And this, coupled with mood and cognitive issues, makes for complicated communication. So some of the strategies include, in order to better communicate with your partner, is having a one-to-one conversation or being in smaller groups. Try to reduce or remove distractions such as TV and music, any background noise. Sit close, make eye contact, and speak at eye level. Actually encourage the person to take a deep breath each time they're about to speak to enhance their voice volume. Give the person time to respond. Don't become so impatient that you ask a question and the person needs time to say it and you start responding for them. And again, don't make assumptions. And one thing we sometimes are not good with is that we don't involve the person with Parkinson's in decision making. We think we know better. And even if people have cognitive impairment, their points of view are valuable. So whenever you're able to, please try to involve them, even if it's time consuming, even if it is frustrating. Other strategies include remaining calm, just smile. People pick up on mood. Don't use sarcasm because that can be misinterpreted. You can use humor, but saying sarcasm, you have to have a level of interpretation that the person may miss. And sarcasm can come across as angry. Also, ask one question at a time. So for example, saying, it looks like today's a very rainy day. Do you want to go out or would you rather stay home and watch TV? Or perhaps we could have lunch. It's just too many sentences, too complicated, and I wouldn't know what to answer to first. Also ask close-ended questions, and an example of that is saying, are you hungry now? So that's a yes or no question. Instead of something like, what would you like for lunch today? That's an open-ended question. Those are more difficult to answer. If somebody's having word-finding difficulties, give hints or cues. And again, when you speak, try to speak in short and easy, simple phrases. For the last few minutes, 5 minutes, I want to talk about how care partners can improve communication with other people in order to help themselves. A lot of care partners are reluctant to ask for help. I get it. I mean, it is hard, especially those caregivers that are really care partners that are in caring professions find it even the hardest. If somebody offers help to you, give them a specific task that they can help you with. So for example, can you pick up my groceries? Could you cook this for me? Could you do laundry? Could you stay with my partner while I run to the hairdresser? Generally, people are happy to help if they know what you need. And you could make a wish list or write a list of things that people can volunteer to help you with. And you can share this list with family and friends. Having said this, I'm very aware that for a lot of care partners, this feeling of family and friends disappearing as the illness becomes more progressive, feeling more alone is a very common experience. And so I don't mean to minimize that you may just not have anybody that you can ask help to. If you have family, a close or even one or two friends that are involved, a good strategy is to have family meetings where you can regularly discuss what's happening. You can really informally talk about, this week might develop some changes in his personality. I don't really know what's going on. I don't know what to do. He used to be so nice and he's just yelling a lot more. And when you share this at family meetings, you have more people to support you and to help you decide what the best approach is. And most importantly, you don't feel so alone. And sometimes these family meetings can occur or should occur with the circle of care in terms of a medical circle of care. If you have a nurse, a social worker, somebody that can support you through these. Scheduling regular family meetings will help you with having open communications, especially for the primary care partner. So don't wait till there's a crisis to have these meetings. Try to have them weekly, bi-weekly, bi-monthly, whatever works for you. And finally, I want to share with you how to communicate assertively and the importance of learning how to share how you feel and what your thoughts are in a way that other people are going to hear you. Assertive communication is different than passive or aggressive communication. When somebody communicates passively, you're not telling others how you feel, and you try to avoid conflicts with others. So for example, your son calls you, "Hi mom, how are you doing?" And you say, "Fine, things are okay." In the meantime, inside you're really angry because he was supposed to take your husband out the day before to give you a bit of a break. He didn't show up and he didn't cancel. But you don't want to deal with this because you feel you're going to create conflict. You're feeling guilty that your son actually has to do anything for your partner. And so that you just push your feelings away and you don't let others know how they're feeling. And you actually let others get their own way. Because if your son feels, well, mom's fine, she didn't seem to care that I didn't come by and take dad out, they don't know what's happening with you. The other extreme is when people communicate in an aggressive manner. And this is when you force your needs and desires onto other people. And in a way, it's good because you express your feelings. The problem is people become defensive and they're less likely to help you. So in the same situation, if you said to your son, "I'm furious with you. I thought you were going to take dad yesterday. You didn't show up. You didn't call me. I can't believe it." How do you think your son's going to feel? His first reaction is going to say, "Hey, I don't like how she's making me feel," and kind of feel guilty. And people that feel guilty, one way that we deal with guilt is we get angry at the person that makes us feel guilty. And so before you know it, your son's angry with you. So a better way to communicate that will get you better results is communicating assertively. And by this, I mean that you express your own needs and desires, but you also respect the needs and desires of others. And by having assertive communication, you can allow both you and your son to engage in a discussion about what's happened. So for example, when your son calls, you can say, "Hi, what happened yesterday? I was a bit worried because you didn't call and you didn't show up. Is everything okay?" And then your son says to you, "Actually, I got delayed at work and then I was just overwhelmed and I kind of forgot that I was supposed to come and pick up dad. I am so sorry." And you say, "Okay, I get it. I mean, you are really busy and I understand. And I probably should have called you and checked in with you yesterday instead of waiting till today, because in the meantime, I've been upset about this." And then your son could say, "I get it. I'm really sorry." And then neither of you have this kind of heated exchange and emotions are more in control. And the more you can control your emotions, the better the communication will be. So you need to respect your own feelings, needs, and desires. Stand up for your feelings without shaming, degrading, or humiliating the other person. Use I statements. For example, you can say, I need a break, or I would like to talk to you to work this out, instead of saying, you're so irresponsible, you never show up to visit your father, you never help me, because that's going to make the person not want to help you. And the last thing is not using should statements. So for example, you can say something like, it's important to me that promises be kept, instead of you should keep your promise. So for example, it's really important to me that next time you say you're going to take dad out, that you actually come through with it or call me and give me the heads up, instead of you should have come, because nobody needs should anything. And with that, I'm going to stop here because I've gone over time, and take your questions.
Thank you, Dr. Shnall, for a very informative and an interesting presentation. As we begin the question and answer portion of our session, we want to remind you that we value your feedback. And after the close of this session, you'll be redirected to a short survey. We ask that you please take a minute and provide us with your feedback. So we now open the forum for questions. And our first question is from Scott. And Scott asks, at what point does a delusion become a medical or police type emergency?
At all points, because it's something that you need to check with the physician, because it could be due to medication and easily solved. So you don't want to wait around. So it depends on the type of delusion, but delusions are not normal to people. If somebody starts telling you something that truly doesn't make sense, why wait? So personally, I think you're best to just call the physician. If you can get a hold of the specialist, at least a family doctor. Did I answer that question?
Thank you. Great. So we've got Matthew with another question here. Matthew says his mother has late-stage Parkinson's. He's struggled with mental health and addiction issues for years, but has attained much more stability in the past year. His two aunts are the ones that look after his mother's care, but they seem not to want to involve him very much, assuming out of fear or overwhelming Matthew himself. Mm-hmm. How might Matthew broach the subject of taking on more responsibility with his mom's care?
So Matthew, that's a really important question, because a lot of the times, in the name of love and not wanting to bother family, adult children in particular get pushed away. And one way to do it is, when I was talking a little bit about assertive communication, is having an open discussion and talking with your mom's sisters and saying, this is what's happening. This is how I'm feeling. I really want to be of support and help to mom, but I'm feeling, and again, I statement, I'm feeling that you're not letting me be involved. Could there be a way that we can all work together? Because if the conversation becomes, you're not letting me involve, you're taking over, you're not letting me, I'm blaming other people, nothing much is going to change, because again, people are going to feel defensive. So again, putting it from the perspective, I really want to help, I'm here to help, how could I help? If the discussion becomes problematic, you don't get what you need, you can always ask for support from a counselor, a social worker, a nurse, an occupational therapist, to help you to strategize how to do this.
Next up, we've got Libby asking, do you have any tips on how to relieve anxiety?
So it depends is the only answer I can give you. It depends what the anxiety is about. Generally, providing a structure, reassuring environment really helps. It depends on the type of anxiety also. Is it anxiety, like just generalized anxiety disorder? Is it around going out? Libby, maybe you can give me a tiny bit more detail about what type of anxiety or what it looks like.
Another question. This is, dealing with apathy is a great source of frustration for care partners. How does one know how much they can push? In other words, when does your encouragement turn into a nagging?
And that's hard. Like again, it's hard to your partner, your family member best. It's important to push a bit, because if you remember that part of your brain not working very well, and unless you push the person to do something, it's not going to happen. But you kind of got to pick your battles. So if you feel that going out today to see, I don't know, the grandchildren is really important, and the person's kind of like, no, they'd rather sit in front of the TV, you push for that. But you can't push for every single thing. So like anything else, pick what's most important and try to do some negotiating as well. So you can say, do you want to visit the grandchildren today at 1, or we can go before dinner, right? So in a way, it gives a person an ability to feel in control, even though you're still pushing to go out. It becomes more difficult around tasks like getting dressed or doing things that must happen, because people, you get tired of just nag. It feels like you're nagging somebody. So pick your battles.
Okay, thanks. Warren has a question here, and his question is, will the delusions or dementia happen in the later stages of Parkinson's or at any time?
So no, not for everybody. Delusions, it's about 8%, hallucinations up to about 50% of people, and dementia may never occur, although about 50% of people do experience cognitive impairment. And again, those are things that are problems with memory, word finding difficulty, but they don't necessarily affect somebody's ability to function too much. So people can still have decent conversations, so they may forget that they just asked you a question, but it's not impairing their ability to do finances, to go walk the dog or anything else. Walk the dog may be a difficult one, but like, again, we call it, the difference is we could talk about basic activities of daily living and independent activities of daily living. So independent activities of daily living are things like driving, banking, doing your taxes. Those are higher skilled activities. Basic activities are feeding, bathing, brushing your teeth, kind of things.
Robert has a very interesting question here. Robert says he can't be the only one in this situation. He has no caregiver, which at this early stage is not a problem. Am I kidding myself that I can face this disease alone?
Robert, what you're saying and experiencing is you're not alone at all. I would assume that 90% of people are in your shoes, if not 100% of people. Because some people have a lot of family and yet they experience zero help and support from others. So it's not necessarily who you have, but the quality of who they are. You will need help at some point, but help could look different depending on how the condition progresses. What's really important is that you have a good healthcare support team. You can always contact, of course, the Parkinson Society, and participate in educational sessions, support sessions, and whatever's available to you. Some people prefer in the early stages not to do much of anything because it kind of not knowing, ignorance is bliss. But the fact that you think about these things is really helpful because it'll help you prepare for the future. Again, engage healthcare team and Parkinson's Society are two good places to start with.
Okay, thank you for that. Simone asks, would having a pet help with cognitive issues?
It's really interesting because the answer, of course, is it depends. If the person's somebody who loved pets, yes. If the pet becomes a source of stress because the person can't walk, it's a dog, or can't care for the pet, that's not good. And I'm just going to tell you, it's not a funny story, but we're at Baycrest at home trialing these robots, like cats and dogs, that are really interactive with a person. They're fake, really, but they respond quite well. They're quite interesting. And I go back and forth with thinking, is this good or is this bad? And I've realized that it depends. So for the right person, these robotic pets are good. For other people, the real thing is better. But if somebody lives in an apartment, they can't care for an animal, then a pet would be a source of stress. So I think that your relative, the person you're caring for, and the supports that they have. And I'm a dog person, so most people react well to pets, but lots of people don't. Some people are allergic to cats. Some people dislike cats. Some people dislike dogs. They're afraid of dogs. A big dog may be problematic. A small dog may be problematic because somebody could trip. So no right answer on this one.
Okay. And our last question is, are there medications to manage hallucinations, delirium, that sort of thing?
Yeah, so for delirium, generally it's an underlying medical condition. And so the treatment would be to treat the underlying medical condition. So if it's an infection, antibiotics. For some of the other things, there are medications, but you really need to consult with the care team, because sometimes really they're due to too much of something, of a medication. So again, it depends on the cause of the anxiety, of the delusion, or whatever may be happening. But please don't delay in asking for help from a medical team.
All right. Thank you, Dr. Shnall. I think that's all the time we have today. We're just at 1 o'clock right now. To our audience or members, as a reminder, please complete our online survey so we can bring you the programming that you want. The link is just above in the chat panel. On behalf of Parkinson Canada, I want to thank Dr. Shnall for a very timely and relevant presentation. For more information, please visit our website at www.parkinson.ca. If you have any further questions regarding today's session, feel free to contact us by email at info@parkinson.ca or call us toll-free at 1-800-565-3000. We remind you that our next webinar will be on April 7th at 12 noon on Guidelines for Parkinson's Disease, 2nd edition. As we sign off, Parkinson Canada would like to wish you all a wonderful day. Thank you for attending.